1 US Central Time. We're at 115 attendees, so I think we should launch the session for today. I'd like to welcome all of you, wherever you are in the world, whatever time of the day it is, to this, which is the penultimate session of our neonatal hemodynamics lecture series. We've got a very exciting talk, speaker, and panelist session for today that we hope you will enjoy. It will be very, very interactive. But before I introduce our moderators for today, I wanted to actually just share one slide with everyone today. And this is a slide courtesy of Laura Thomas, who's the program coordinator for our Neonatal Hemodynamics Research Center. And 2023 has been another amazing year in the growth of the field of neonatal hemodynamics. The Neonatal Hemodynamics Research Center footprint has continued to expand. We now have 140 faculty across 77 sites, which is an increase of 45 since the prior year, and an additional 31 sites. Currently, we have 50 trainees across 26 sites that are part of our consortium. And if you look on the right-hand side, our webinars at the level of NHRC and this lecture series are highly attended. We've had an average of kind of somewhere between 250 and 350 attendees for these particular sessions, which really is a strong endorsement that the world not just wants neonatal hemodynamics, but also needs neonatal hemodynamics. It would be remiss of me to not kind of end the year without acknowledging the brilliance of Reagan Giesinger, who we sadly lost in May of this year. Her contributions to the field were immense. Her legacy is assured, and she has inspired many, many young neonatologists all over the world to follow in her footprints. So without further ado, I would like to introduce our moderators for today. First, I would like to introduce Dr. Faith Zhu, who is a neonatologist from Mount Sinai in Toronto. Welcome, Faith. And her partner in crime for today is our good friend, Dr. Amir Ashrafi, the entertainer from California, who will keep everyone on their toes today. I think you guys are going to be a fantastic team, and I will hand over the floor to both of you and look forward to the rest of the session. I would remind everyone to put your questions in the Q&A session. We will try to get to as many of these as possible. If we don't get them answered kind of in the session, we will try to reply afterwards. So Amir, Faith, welcome.
Great. Thank you so much, Patrick. Big congratulations to you, to your team, to the NHRC community for that phenomenal growth in such a short period of time. And you're exactly right. This is the time for us to expand our neonatal hemodynamic knowledge and horizon. And there's no better person to help us do that than Dr. Anup Katheria. If you want to turn on your camera, Dr. Anup Katheria, I could introduce him in a couple ways. You know, if you want to be formal about it, Associate Professor of Pediatrics. He's the director of the Neonatal Research Institute at Sharp Mary Birch. He's the director of the Neonatal Follow-Up Clinic at Sharp Mary Birch. And you can go on and on and on. But really, my favorite part about Anup is all the other stuff. He's just a class act. He's a thought leader. Whenever I have any questions, I go to him. I can't tell you the number of times me and my division chief have been at a restaurant talking shop. Next thing you know, we get into an argument about physiology. Should you do it this way? Should you do it that way? And every single time my boss calls Anup Katheria. How many times have we bothered you at like midnight, 11 p.m. just say, hey, what do you think about this? So he's our go-to guy when it comes to controversial matters of the delivery room. And like I said, he's a thought leader. So let me turn it over to Anup to enlighten us on this important topic. Take it over, Anup.
Thanks, Amir, and yeah, thanks again for those phone calls, and just a special thanks, for that lecture series that Patrick has run to honor Reagan, who was a colleague of mine. I think many of us external to Iowa have a lot of regard for the work that she has had done over the years, and really posthumously continues to do as her work gets published. So let me just share my screen here and get started. All right, so Patrick asked me to talk about hemodynamics of cord clamping, and I spent a lot of my career looking at this, but really trying to learn a lot from the physiology, both in humans and in animals. And hopefully from this talk, at the end of the day, you'll have a better understanding of how we try to interrelate the two. Because while there are things we can only study in animals because we can't truly get the physiology right at birth, I think it's important to see how we extrapolate that to humans and more importantly, into trials when we make recommendations for cord clamp, because I think there are some things that we might have missed as we were trying to sort of marry the two. So no conflicts. We'll be reporting a lot of the data from several grants that we've been funded on. And again, special thanks to Satyan, who's one of the panelists on here for a number of his remarkable drawings that help really explain a lot of this topic. This is one of my favorite really overview slides. When we talk about placental transfusion, moving blood from the placenta towards the infant, there have really been two camps. And I really think instead of separating the two, we need to talk about how they really interact. And there's the camp that says, well, the blood is the most important thing, that this is, fetal blood, which is high in hemoglobin F, has thousands and billions of stem cells in it, and has the potential to really improve neonatal outcomes by providing this blood, which is full of iron, can improve hematocrit, decrease the need for transfusion. On the other end, you have the hemodynamic camp that says, well, look, it's not less about the blood going to the baby, but in fact, the fact that you're avoiding clamping the cord and allowing the baby to transition, having better oxygenation, therefore reducing the PVR slowly, decreasing ductal shunt, and maybe that's the reason why we see less IVH. But at the end of the day, when you look at the neonatal trials, and I hope by the end of this talk, that's what we focus on, is what is the clinical evidence for this, which are what are the outcomes that we're seeing in these infants, such as the reduction in mortality in preterm babies, and some of the trials that have suggested a benefit in neurodevelopmental outcomes. And the evidence for blood transfusion or placental transfusion is pretty clear, even from studies back in the late 60s, when you looked at here in the red bars, that if you wait out to 3 minutes compared to early cord clamping, you can see that you get an increase in blood volume by over 30%. And this was in the era where we could truly measure blood volume looking at tagged RBCs, whereas nowadays we have to use hemoglobin, which isn't as great of a marker for looking at the degree of placental transfusion. Now, this is a great overview slide that Satyan put together that talks about some of the mechanisms of, well, how do you go from in utero, where blood is just moving back and forth towards the infant, to after delivery, where now you're getting a net transfer of blood into the baby. And really these four factors come together to really deliver the sort of optimal placental transfusion that we want to see in all of our newborns. And if you start over the left here, we know that, and I'll show you in a few slides, that vaginal delivery, keeping that uterus intact, is probably one of the best mechanisms for a placental transfusion, that you're getting that squeeze on the placenta. And there's been debate about contractions and gravity, and I won't spend too much time in that in this talk, but really at the end of the day, if you're delivered vaginally, you get a better placental transfusion than by cesarean section. We also know that after birth, the umbilical arteries tend to spasm. So it's sort of the opposite way of thinking when you look at cord blood, that the umbilical vein is what's sending blood towards the infant, that oxygenated blood, and then the umbilical artery is taking blood away from the infant. So as that artery tends to spasm, you tend to get a net transfer of blood towards the infant. And then more recently, again, adopting some of the animal data into human data, which is that the babies need to have breathing in order for placental transfusion to occur. That negative intrathoracic pressure with spontaneous respirations essentially is pulling blood in from the placenta towards the lung. And then lastly, but probably most importantly, you need to have a beating heart. If you don't have a good heart rate or any heart rate activity at all, you're not going to get blood being propelled from the umbilical venous circulation into the pulmonary circulation. So if all these things happen together, you get this nice, pink, healthy baby, and all is well. And we see that every day with full-term vaginally delivered infants. But it's these caveats in the preterm and other modes of delivery that we really need to get into. Now, the debate about C-section has been going on for quite some time, which is, well, what is occurring during cesarean section? Well, if you look at animal data, and this is from Stuart Hubert's lab in Australia, they've shown that whether you have the baby held above or below the level of the uterine incision, or even looking at the net blood flow, there makes no difference in terms of blood transfer in an animal model during cesarean section, suggesting, in fact, no placental transfusion occurs during cesarean section. Now, there haven't been very good human studies that have been done as of recently, but there's a really older study by Alexandani and the group in the UK that looked at comparing, again, when they could do this method of doing tagged RBC studies and measuring true blood volume in these infants. And you can see here by the letters, the letter V represents a vaginal birth, and the letter C is a cesarean section. Here are vaginal deliveries that got crossed over to cesarean sections by these circles. But looking at blood volume here on the y-axis and on the x-axis, the time to which you delayed cord clamping of the cord, you can see the longer you went out, the vaginal delivered infants are the ones that actually had an increase in blood volume compared to cesarean section that did not have much of an increase. Now, some have said, well, the difference here might just be due to a net shift of blood from the placenta back towards the infant during labor, and in fact, that there is no net transfer. But I would argue that, in fact, there is some placental transfusion happening during cesarean section. In fact, the group in Sweden by Ola Andersson actually demonstrated that if you compare cesarean section compared to early cord clamping, shown here in the middle, compared to doing a true delayed cord clamping about to 3 minutes out of vaginal birth, you still get some increase in hemoglobin levels. And again, this is measured in grams per deciliter, but you can see there was an increase compared to early cord clamping when you looked at C-section babies, but not as high as when they're delivered by vaginal birth. So C-section may not be ideal, but it may require more time for placental transfusion to occur, but that's something that we still need to further explore. Now, when we're looking at trying to extrapolate the data that we're seeing in animals, this is probably the most famous animal study that's been done. Really had been coined the term that many are now using called physiological-based cord clamping, where they took preterm lambs at a mean gestational age in humans of 26 weeks and said, okay, in one group, let's clamp the cord early and wait 2 minutes and then ventilate these lambs and see sort of how their heart rate and other hemodynamic parameters respond. And then the other group, instead of clamping the cord early, will continue to ventilate these preterm lambs and then clamp the cord close to 2 to 3 minutes of life. And what they found here was there was a dramatic difference in their heart rate. If you can see in the black circles are the lambs that got early cord clamping compared to ventilating the lambs. And many of us, including myself, thought, okay, look, this is the argument of why we should ventilate preterm babies continuously to avoid this profound bradycardia. Now, shortly thereafter, I would say about 2 years ago, another group in Australia said, well, wait a minute. What if you don't ventilate the lambs or you don't wait to ventilate the lambs as long? So instead of waiting 2 minutes, let's wait just 40 seconds. Because normally when we do early cord clamping in a human, we don't wait 2 minutes before ventilating or providing some respiratory support in babies, particularly if they're apneic. And in this case, these lambs were completely anesthetized. They had no opportunity to breathe on their own. And what they found here was that, again, in the group where you ventilated them continuously, you saw this nice stable heart rate. But if you clamped early and then ventilated them soon after, in fact, their heart rates were not only lower, they tended to be even higher in these babies. And I'll get into this heart rate mechanism, why it probably differs a lot in humans than what we're seeing in the lambs. And so in reality, this model of looking at heart rate as a measure of whether placental transfusion is a benefit probably isn't a good one. In fact, there's probably many other things that are happening hemodynamically in a human than what we would expect in a lamb. And this gets into the important differences between lambs and humans. When we look at a sheep placenta, and these are some nice slides that Satyan put together for me, you can see here that instead of having one unified placenta, you have these little almost mini placentas or cotyledons that fuse together into one umbilical cord, and that cord is very, very short. And if you look here, it's only about a few inches long compared to what we see in our preterm babies of cords of 20 to 30 centimeters in length. And these cords have no Wharton's jelly. They have 2 umbilical veins and 2 arteries. And so the model, while it's great at looking at acute cardiovascular changes, when we're looking at a placental transfusion, it may not be as ideal. The most important take home I would say for us and for the audience here is to remember, in a lamb model, there is no placental transfusion. Here, you look at the bottom right, you can see that the amount of blood flow going in, coming out, looking at net blood flow in the umbilical vein and artery, is essentially 0 if you look at it over time. There's no increase as you would expect in a human. Now, there are important take-homes that I don't want to get away from when we're looking at some of these physiological changes, but if you're looking at a model where you're looking for a placental transfusion to occur, this is not going to be the ideal model for it, because we don't do these things to humans that we do to lambs. We don't drain lung fluid, instrument them, and intubate them before we start resuscitating them. So part of this is to take the sum of the data and what we can extrapolate, and then looking at some of the human data that I'll show you in terms of hemodynamics. So let's get into some of those human trials now. This first one isn't actually a randomized study, but it's a good hemodynamic observational study where they looked at babies during delayed cord clamping and said, what's happening to the blood flow in the ductus venosus, right? When we think about the umbilical cord as umbilical veins going into the baby, the ductus venosus would give us a good idea, at least a surrogate measure of blood flow going in from the placenta towards the infant. And what we can see here is that during inspiration and expiration, most of the blood is anterograde. So we're going to get the majority of the blood flow going towards the infant as these babies are starting to inhale. And I think this is really strong evidence that it's not actually a back and forth where it's equal. Most of the blood flow is going towards the infant, not out, as you would expect in the lamb model. So I think this is the sort of first part of looking at it. And as blood's going into the baby's heart, now we have to think about, well, what's going to happen to the hemodynamics of these babies? So we have a few good human studies. This first one on the top left was just published a couple weeks ago by the group in Cork. And they looked at term babies that were getting during a cesarean section and actually did echocardiograms during delayed cord clamping in the OR. They clamped the cord, did another echocardiogram, and then one more 5 minutes after. So I applaud the group for really doing very detailed studies on these babies. And what they showed is that the cardiac output measured by LVO actually incrementally continued to increase during the delay, after the cord was clamped, and even 5 minutes later. And you put these things together, you can only imagine now what's going to happen to the other parameters, looking at stroke volume and heart rate, et cetera. Our group in San Diego looked at 20 babies, and we put on this device shown on this baby here called electrical cardiometry. It's not the same as doing an echo, but it measured stroke volume and cardiac output in these infants. And you could see that every minute the baby remained attached to the cord, the cardiac output or stroke volume went up by about 13%. And by 3 to 5 minutes, you can see it was significantly higher than what was at baseline. And then lastly, this group in Egypt did the same thing, even doing it further out, looking at delayed cord clamping showed here in the dotted line compared to early cord clamping, you could see higher stroke volume and cardiac output in these infants. So again, when you look at delayed cord clamping in a human baby, you're seeing improvements in cardiac output, not just a stabilization for what we were seeing in the animal models. Now, when we take it looking at resuscitation with an intact cord in high-risk newborns, babies who need resuscitation, there's been a few studies. One was by our group a couple of years ago, looking at term non-vigorous babies. The group in Australia did another nice trial called the Baby Duck study, and then there have been 2 studies in low middle income countries in Nepal and in India. And all of these studies, interesting, if you could take them, combine them together, you can see that they did show acute improvements. These babies had higher APGAR scores in the delivery room. They had better oxygen saturations in the delivery room. So things that you'd want to see while you're resuscitating babies with an intact cord. And when you look at heart rate, interestingly, the heart rate went down. Again, getting into the physiology, if you're improving cardiac output and stroke volume by all this extra preload, you'd expect the heart rate to go lower. Unfortunately, and this is what we're struggling with the evidence, we haven't seen a difference in clinical outcomes. And so I think it gets into what are we really looking at in these babies and which types of babies we're studying. And I'll use my own study as a criticism. This is a baby that we did intact cord resuscitation on. And you could see here that this is a preterm baby around 28 weeks. And this baby's not depressed. He's not non-vigorous. This baby actually, once you see us start to ventilate the baby's hand is up in the air. He's almost pushing the mask away, saying, like, I don't really need this done. And the baby actually is fine. But what we're trying to do, at least we thought we were, was to try to open up the lungs more while they were getting a placental transfusion, and thereby improving the amount of hemoglobin and then some of the downstream outcomes in these babies. And this is the area that we need to figure out which babies actually need this done or would benefit the most from it. And I highlight this because while most of us that are in the US are watching this think that this is completely experimental, some of you on this call right now are actually from Europe and other countries are like, this is standard of care. We're already doing this. If you look at the European guidelines in 2021, this is not even this past year, this is a couple of years ago, they actually stated in their guidelines, if you can provide adequate thermal care and the initial resuscitative intervention can be safely done with the cord intact, it might be possible to do delayed cord clamping while performing these interventions. And again, this is a non-disclosure talk. I have no vested interest in any of these companies, but you can see here, there are carts that are developed in Canada, in the Netherlands, and then here in the UK. have all developed these trolleys that are being sold at very high levels, demonstrating, in fact, that we can provide this support and it can be done as part of routine care. These are not even as part of trials. But again, it gets into the evidence. Where are we at with using intact cord resuscitation? There have been 3 trials just presented. These are not even published, so I don't want to give too much more in detail than what I have on this slide here, but the VENT-FIRST trial was just presented last week at Hot Topics. They randomized 568 babies using 30% oxygen with an intact cord compared to delayed cord clamping alone, and showed no difference in their outcome of IVH. The Italian trial did a similar thing, looking at 30% oxygen for 3 minutes and compared it to cord milking and showed no difference. And then the ABC2 trial that was presented at JENS last year looked at 660 babies giving 30% oxygen compared to delayed cord clamping alone and showed no difference. And you can see here that there's differences in the duration of ventilation. You could have gone 2, 3, or if you were doing physiological base cord clamping, you might go 4 to 7 minutes to make sure the baby's oxygenating great. No matter how long we've gone, we've still not demonstrated definitively that this is better than delayed cord clamping alone. And for some of you, I think we're struggling to even do delayed cord clamping successfully. If you look at some of the trials that have done delayed cord clamping in terms of different durations, the first trial that used one of the shorter durations by Judith Mercer at Brown did 30 seconds of delayed cord clamping, and they had a very high adherence rate of 86%. The Australian placental transfusion trial, 1,600 babies, looking at 60 seconds delay, only 74% of those babies got the intended intervention. And then in the UK, they did a 2-minute delay, and 59% of those babies got the intervention. So we have to ask ourselves, even if in research trials we're struggling, how are we going to do a longer delay as far as clinical care? And what are we looking to achieve in these babies? When we look at things like when babies are starting to breathe, this is from the study, that video I showed you. Well, we really believed that ventilating babies was going to show better outcomes than just delayed cord clamping alone. And we looked with video, like I showed you there, when these babies actually started to breathe. And we saw that at 20 seconds, only about 40 to 50% of babies were breathing. And if you're going to use breathing as a decision whether to continue to do delayed cord clamping or not in preterm infants, I'll say for the most part, you're going to be wrong. You need to give babies time to be able to ventilate on their own by performing stimulation. Because in fact, the stimulation group, or the control group shown in blue here, had the exact same onset of when they started to breathe. And it wasn't until they hit 60 seconds that 90% of these babies started to breathe. And I think that's the part that we really need to figure out, is that we can do this successfully, but what group we think are going to benefit the most. Now, in terms of thinking of the preterm baby, I showed you some good data in term babies, how they oxygenate better with delayed cord clamping. What's interesting that in preterm babies, when you do delayed cord clamping, and we see this a lot, you have a 23, 24 week who comes out, they might be vigorous, crying, even breathing on their own. By the time they get to a minute or so, they sort of stop breathing. They're starting to get apneic, and then you bring them over to the warmer, and their first SAT is lower. And in fact, in our pre-Mod 2 trial, and I'll talk about the milking portion in the second half of this talk, but we saw that the babies who had delayed cord clamping compared to cord milking actually had lower oxygen saturations by 5 minutes. And so if you look at sort of where 5 minutes and this dotted line fall here, it's a good portion of these babies that have lower SATs. Now, I'm definitely not advocating for cord milking because we know it's not safe in these extremely preterm babies. But what are we doing with delayed cord clamping that we could optimize better to improve how these infants are doing? And you may say, well, what's the big deal of having a low SAT at 5 minutes? That's not really associated with anything negative, is it? Well, if you look at some of the oxygen studies, it actually is. Having a low saturation at 5 minutes of life, again, less than 80%, when they looked at all of these oxygen studies, you can see a number of the authors from the Torpedo trial, the PreSox trial, or the RESET trial, all have shown that you're more likely to die or have severe IVH by almost 3 to 4-fold higher if your SAT does not hit 80% by 5 minutes. It's almost like the first early biomarker for morbidity in the delivery room if you cannot oxygenate well by 5 minutes. And I think this is something we have to think about when we're saying, well, we're going to do more and more delayed cord clamping. We're going to go longer and wait to provide support. What does that mean for our babies? Now, part of the issue with delayed cord clamping, as I highlighted early on, is breathing. If you're not breathing well, that's not going to necessarily help you with placental transfusion. It may not even help you well with oxygenation. And we know early on in this first minute that we're hoping to achieve delayed cord clamping, that the airway isn't really open a lot. And then this has been shown again by this group in Australia that in fact, when they looked at glottic opening, most of the time it was closed in these first few minutes of life. And it took almost an hour before it remained fully open. And some of the studies by our group, as well as Doug Blake, one of our old fellows, demonstrate that it takes a long time before you actually see color change if you use a colorimetric CO2 detector. And some of the things that contribute to this are low oxygen levels and cold stress. So we need to improve the environment for these babies to allow them to breathe better. Now, this might seem really archaic to some of you listening here, but what about going back to a higher level of oxygen, going back to even 100%? Now, this may seem sort of cyclic to many people, but in fact, this group in Leiden actually demonstrated that you can safely start at 100% and wean babies down fairly quickly. And this initially had nothing to do with cord clamping. This was just routine resuscitation of preterm babies, where in the light blue, they started at 100 and they went down very quickly. So by the time you looked at the first 10 minutes of life, the amount of oxygen exposure in these babies were identical. But what wasn't identical was the saturations in the first 10 minutes. As you'd expect, if you give a baby 100% oxygen, even for a brief moment and wean quickly, you're likely to saturate better by 5 minutes, where in fact, most of the babies, if not all the babies, were saturating above 80% by 5 minutes of life. Now, the trial didn't have any neonatal outcomes, so this is still very preliminary data. But what was really interesting to me was how these babies were breathing. When they performed respiratory function monitoring on these babies, they got 100% versus 30%, again, just for those first few minutes and then titrated quickly, you can see that their average minute volume or tidal volumes, or even the trends in the respiratory rate were all higher when they had higher amounts of oxygen. Now, again, this is all happening after the cord is clamped, but what if you did this during delayed cord clamping? Now, the people that are most worried about this are going to say, well, what about the antioxidant damage? We have lots of evidence showing that this is harmful. Well, they did look at measures of oxidative stress at an hour and at 24 hours, and there was no difference. Now, you could argue that in the Torpedo trial, which was the trial that compared 100% to 21%, a large portion of the babies who died at 21% was from probable early pulmonary hypertension. And we worry about early pulmonary hypertension in some of our preterm babies with respiratory failure. And by the time we give them oxygen after the cord's cut or much later, that might be too late and actually more damaging to these babies than we might have thought. Now, the last piece of evidence I'll give you for 100% before we sort of talk about some of the work that we're trying to do here is this has not been published yet, but this is the net motion. This was presented at the GENS meeting as well, which did individual patient data analyses to look at all the trials that had a high amount of oxygen, intermediate, and low. High was above 90%, which are most of the 100% trials. Intermediate was 50 to 65%, and low, which is what I think all of us on this call are using, which is 30% or less to start resuscitation. And what they found in this study was the only group that had the lowest odds ratio for death, and this is death before discharge, was high versus low. So giving 100% compared to 30 or less, those babies had the basically the lowest odds ratio for dying out of these different groups. So this is pretty strong evidence for using higher amount of oxygen, but yet we haven't had a large trial looking at this. And on the flip side, another big meta-analysis, and this one is published, was looking at delayed cord clamping. And they compared over 6,000 babies in 47 trials and looking at short deferral, medium deferral, long deferral, or milking. And long deferral was waiting to clamp the cord at 2 minutes. Short deferral, which I still see many people do, is 35 to 15 to 45 seconds. And medium is sort of in between. And the only group that had the highest ratio for reduction of death was long deferral. So going longer is probably going to be beneficial. And so I sort of ask for people to think about, if you can go longer and provide more oxygen, could this be the mechanism by which we provide benefit for many of these babies? And so looking at better placental transfusion and lung aeration, this is a nice schematic from Satyan, including some animal data showing that, in fact, the safest way to give 100% might actually just be on the cord, because now you got this wonderful buffer of the placenta that's going to dilute all of this extra oxygen that may be coming into the pulmonary blood bed, because it's getting diluted by deoxygenated blood from the placenta, causing minimal oxygen toxicity. And you again show that in a lamb model here, showing that the PaO2s do not increase if you give 100% while the cord is intact compared to giving it after, where you overshoot. And you also see better oxygen saturations over here. So I just wanted to have a few minutes to talk about milking, but just really quick, we do have a pilot trial going on right now, led by my mentor, Neil Feiner, along with Satyan and Robin Steinhorn, to really look at whether we can improve oxygenation in these babies by giving them a brief exposure just while the cord is intact for the first 90 seconds, and then clamping the cord and then resuscitating them on 30%. Is that better than just doing 30% oxygen on the cord? And so hopefully more to come with that study. And so just before I go into milking for the last 5 minutes, just some take-home points with resuscitation with an intact cord, that if you at your institution are not doing well with delayed cord clamping, don't focus on buying a bed and doing resuscitation. Focus on stimulation. Get your obstetricians to stimulate babies, because you're more likely to get them to breathe in that sort of first minute than trying to get a bed and trying to extend these things. If you're looking to go longer, out to that 2-minute group, that's where I think providing some oxygen might be beneficial with these babies. And think about whether higher is better, but we still need the evidence for that. And then really quick, let's talk about milking. I think there's been still a lot of controversy about cord milking, which group, what could benefit. Should we do it at all in babies? And I hope I can convince you that while this is the data that we've seen from the animal model, again, if you milk a cord in a lamb that doesn't accept a placental transfusion, what happens? The blood just comes right back. The only way to get blood into a lamb is by aerating the lung. And that's been shown by both the group in Buffalo over here on the left and the group in Australia, that once you start ventilating the lambs, the blood goes in and doesn't come back out. So I think part of this is to try to think about how do we apply this model in babies, because what I really think is happening, even in the preterm babies that had poor outcomes, the first trial we did was a hemodynamics trial. I mean, I started off my career as trying to do echoes on as many babies as I can and making that the primary outcome. And we showed that milking the cord in preterm babies born by section, because a section was a group we wanted to facilitate a placental transfusion, had better SVC flows and RVOs, and as shown, the dotted line had better blood pressure. And as many of you know, we did a large multi-center trial, and what we found was there was harm in babies that had cord milking compared to delayed cord clamping, but particularly in these tiny babies, 23 to 27 weeks, where you see a 4-fold increase in severe IVH. But I think people also miss this bottom slide here, which is most of the signal, in fact, all of it, was in the vaginal born infants. It was not in the babies born by cesarean section. So it's that squeeze on the placenta with milking the cord that causes harm. So I'm not going to spend too much time on all these animations here, but if you haven't seen it, it's a beautiful one that Satyan put together, that as you squeeze the cord, you send blood across the umbilical vein through the PFO because your pressures are high, particularly in these 23, 27 weekers. You also might be increasing the amount of blood flow in the aorta as well, increasing systemic afterload. All of these things combined end up increasing the amount of blood flow seen by the brain, and therefore you might be seeing increased severe IVH in these babies. So that's the sort of how we speculated. We worry about the tiniest babies, particularly born by vaginal birth, but in general, the recommendations are not to milk any of these kids at that gestational age. Now, the uphill battle I've been fighting is, what about the rest of the babies? Should we just stop it on all the kids? So we continued the trial and we looked at babies 20 to 32 weeks in 20 centers. So these are centers that are all milking. If people are worried about, well, is milking being able to be standardized? Well, we standardized it enough in 20 centers in 3 different continents to try to make this facile enough. And what we found in over 1,000 babies is that IVH doesn't increase. In fact, you're not seeing any differences in severe IVH between the groups. And as we might have speculated, milking kids in C-section are actually even lower when you're looking at interaction effect by mode of delivery. And if you look at hemoglobin, again, we think the transfer is better at C-section by milking because you're actually pushing some blood into these babies. So it's probably helping those kids. But the challenge is, how do you get over some of the animal data and the really small baby data that we've seen? Here's the forest plot. If you're looking at, these are 1% percentiles here, really no difference across the board between the two. But I know many people are still very nervous of doing this, so I figured it would be best at least to share this. Okay, I know I'm 1 or 2 minutes over, but I'll just show you a few more slides here. That babies above 28 weeks, this is the sort of mechanism. But I wanted to show you the MINV trial, which is even older babies, 35 weeks and up. And we looked at this across 10 different centers. that in babies who were only non-vigorous, babies who could not receive delayed cord clamping, and again, we showed benefits with milking. They had less respiratory support in the delivery room, higher hemoglobins, less HIE. This is a group we're trying to reduce HIE by any method possible, and I think this is probably a huge benefit for low middle income countries. And then of course, you can't do a hemodynamic talk without hemodynamics, and we improved a number of outcomes, both on the left and right side of the heart, including reducing the need for oxygen levels, oxygenation, or reducing the need for oxygen in the delivery room as well. So looking at a lot of these things to try to prove safety, I hope if I was going to give you one take-home slide for milky, this is a nice guideline that Satyan put together. This is actually, at least in the United States, has already come out. We're still waiting for ILCOR for the rest of the world, but milking is now considered a reasonable option if you're non-vigorous and you cannot do delayed cord clamping. It's the first time we've come out to say anything about babies who need resuscitation and the cord management. Historically, because there's no data, ILCOR has remained silent on what to do with the cord if the baby needs resuscitation. So just the sort of take-home points, if you're looking at sort of the hemodynamics and cord clamping, I think it's a number of clinical factors that can affect this. I think you need to look at everything from mode of delivery to the type of gestational age patient that you're looking at and the situation of whether to milk, do delayed cord clamping, or even consider doing something like intact cord resuscitation. But really trying to understand the animal data and what are the things you can translate is key. And looking at what we can do in clinical trials that can sort of help us understand the same types of physiology that are happening in these babies. So again, I can't take credit for a lot of this work. Most of it was from all of these people here. A number of our centers and PIs and trialists have really helped us all over the world to collect these data. And of course, my wonderful research team over here on the bottom right could not do the studies without these guys. So thank you to them. Thank you, Satyan, for all your drawings that make these talks so much more fun to give. And I'm sorry, I went a few minutes over. Couldn't help myself, guys. Thank you.
Thank you so much, Anup. That was really quite a wonderful talk. I believe everybody will have lots of questions coming up, but in the meantime, I'm going to start introducing our panelists. So we have three wonderful panelists for here today. So I'll start with Dr. Battersby. So Cheryl Battersby is a consultant neonatologist at the Chelsea and Westminster Hospital in London. She's also a clinical senior lecturer in the Center of Pediatrics and Child Health at Imperial College London. And she has a whole wealth of experience and research knowledge using database research and neonatal medicine. And we're really pleased to have her. I believe it's the first time here in our NHRC Pan-American talk. And second panelist here today, we have Satyan Lakshminrusimha. So Satyan, you guys have really appreciated all his drawings, I know, from Anup's talk. And he is the Nancy and Dennis Marks Chair of Pediatrics and the Pediatrician Chief at UC Davis Children's Hospital. You've heard a lot about his research in the animal model, and his primary focus is about fetal lung changes at birth and disorders of transition, in particular with asphyxia and PPHN. And finally, we also have Audrey Hébert. She's an assistant professor of pediatrics in the neonatology division in Laval University and a staff at Children's Hospital in Quebec. And she has developed a research field in chronic pulmonary hypertension and BPD, and has a wonderful training program in TNE. So we're really pleased to have all of you guys here today.
All right, excellent. Welcome, everybody. Anup, phenomenal job as always. Let's start 60,000-foot view and then just get more and more narrow. As you heard from Faith, we've got a phenomenal group of panelists. I'm just going to open it up broadly. What did you hear that you want to amplify that you heard Anup say? And what did you hear that you're like, wait a sec, I don't know if I necessarily agree with that. That's not exactly how we do things at my institution. Let's just start broad and open it up there to the panelists.
Yeah, so I'm very happy to come in. So fantastic talk, Anup. Excellent body of research. Congratulations. It's really impressive. And thank you for advancing this field. I say that because, as you know, we have looked at across lots of databases, trends in terms of our improvements in mortality and morbidity over the last 20 years. And you would have seen the latest Vaughan paper, which looked at 888 centers, and very sobering that we have not seen an improvement in our outcomes in terms of mortality and morbidity. And perhaps it is because we've just saturated the actual limit of our interventions. We know that our antenatal steroid rates are above 80-something%, even in the UK. And we've just looked at our data. So we have the National Neonatal Research Database, which looks at all nearly 200 neonatal units across the England and Wales. And we've also found exactly the same, where we've not seen improvement in outcomes, despite a huge national drive to really focus on those perinatal optimization, including delayed cord clamping in the last 2 years. So our data was up to 2022. So my question to you is, do you think this is the holy grail of improving outcomes? Because as you know, as you've said quite eloquently and politely, that we haven't quite reached absolute optimization of this. So in the UK, we started cord clamping a couple of years ago, and we know it was extremely poor. It was down 30% for our less than 34 weekers, and now it's improved to about 60%. It ranges now between 40 to 70, and one unit hit 80%. We have a national neonatal audit program here, and we look at their data annually. Do you think we should be really, banging that drum harder and really sending that message out about the importance of delayed cord clamping or deferred cord clamping, given, the really quite convincing evidence from the IPD meta-analysis and lots of other body of literature?
Right. No, I think that's great. And I think you summed, the global sort of mission of really finding out which interventions are the most impactful. I wish we could say for sure we've demonstrated, or even that meta-analysis demonstrated clearly that this is going to be the holy grail to solve all of our problems. And as we know, it's so multifactorial when we look at, why do babies even die? Even look at the cord clamping trials, how do those babies die of? And it's very unclear to know that. I do think, though, if you look at all the interventions in neonatology, this is as simple as breastfeeding and washing. So because it's so low tech, because it's so easy to do, it should be we should treat it the same way. You have a national audit for delayed cord clamping in your country. We have nothing of the sorts in the United States. Even within states, we're trying to do a better job. Yet we're very big on reporting our breastfeeding rates. We want to report our infection rates and how well we hide. We even have people spy to see how well you hand wash. Nobody wants to know whether or not delayed cord clamping is being done effectively. We don't audit it as clearly. We don't have people watching it. So I think it's important. It's not going to solve our mortality issue per se, but I think it should be implemented the same way. We should treat delayed cord clamping the same way we treat breastfeeding. We make that a mainstay. Parents need to ask for it the same way they do breastfeeding. And they will eventually. The Lancet meta-analysis was in every sort of global newspaper. It was in the New York Times. People are talking about this, like, what is this? And yet and that's probably what we need to do more of, is highlight that this should be the most important thing we do to start off birth. So it doesn't answer your question if it's the most important, because of course, with respect due to the breastfeeding compound, people that have done so much work in reducing other morbidities with that. But I think it's up there. It should be our top 5, I would say, of interventions that we do on every baby to ensure they have the best start for their outcomes.
Yeah, because it's a simple intervention. Breastfeeding, there's so many socioeconomic factors which go into that. And I just think it's something we really need to put up on the agenda.
Agreed.
My next question really, sorry, can I have another question?
I'm good with it.
I guess my question is, there are potential added benefits of that stem cell transfer, isn't there, with the umbilical milking? Do you think that's potentially very exciting as a sort of hemopoietic? It could solve potentially lots of other pathologies like NEC, HIE. Right. Do you think that's a promising field?
Yeah, absolutely. I always have to be careful talking about milking compared to delayed cord clamping, because I still always think delayed cord clamping is better. But I know other people have probably replicated in the lab, but we did a small translational study and demonstrated that milking actually extracts more stem cells than delayed cord clamping alone. That sort of mechanical dislodging of cells that are actually along the endothelium of the umbilical vein. And so Atul Malhotra in Australia is actually looking at milking as another adjuvant therapy for babies with brain injury, necrotizing enterocolitis, as you're saying, as well as maybe there's a method where that blood can be beneficial for certain populations. The bias I always have is extracting that blood and giving it later. How is that necessarily superior than giving it right at birth to all those babies? Sort of, it may be indiscriminately, but are there sort of that, is there a way to sort of look at those things? I know the challenge with doing human studies of stem cells, particularly in the preterm population, is they're very hard to detect and be able to look at the sort of net transfer in these babies. But you raise a really good point. As one of the benefits we're missing here is the reparative benefit of placental blood because of these billions of stem cells going into the babies. Could we see other things downstream as these babies recover because they have this bolus of stem cells? It's great to talk about, but I don't have any evidence to sort of give back to you to say that we've actually proven this. But it's a great point.
All right, I've got more questions, but I will hand back to the moderators because I realise I've taken two. Thank you.
No, those were really excellent questions and really thought-provoking, but we'll take a question from our audience. So we have a question, well, actually two-part question from Jay Banerjee on our chat. So I guess great talk, very impressive work that you've done, Anup, but I think the questions really here are there maybe some objective measures that we can use to suggest when we should clamp the cord? And then the second part really is about patient selection. Are we selecting the right patient? Should this be individualized as well, depending on the condition of the baby? And maybe I'll first get Audrey to open up this question, and then we can see what the rest of the panel thinks.
Well, there's two ways to answer this question. A great question, by the way, so thank you. There's the evidence-based answer to that question, and really what is the practical of what people are doing, or what even at the lowest evidence, which is what I think I would do, or what I'm doing in practice. So evidence-wise, we've already seen now from one of the trials that I presented that hasn't been published yet, which was looking at markers, and that's the ABC trial that said if you need to have a saturation of 90% or higher with a stable heart rate and stable breathing pattern to then clamp the cord, and that took 5 to 7 minutes. And that still didn't show a benefit. And so presumably, though, that was supposed to be a personalized approach where the sicker baby maybe was on the cord longer than the others. That being said, in a sort of, I'm on call today. If I have a baby that has a tight nuchal cord or has severe bradycardia in his section, if I can reduce the nuchal, leave that baby on, I would want that baby on the cord longer than the baby that came out is vigorous and is moving around and doing well. Now, that is a hard thing to do in practice. Those are the types of situations where you have to be in there, really counseling the OBs and helping them feel comfortable, stimming the baby and giving that baby time. I do think those are the babies that benefit the most, but it's so hard for us to do that in trials. But the answer I gave you, though, was not a heart rate, was not an oxygen saturation or a NIRS probe. It's something just really practical. The babies who are floppy and not doing very well are likely to be more hypovolemic and likely to benefit from that extra blood coming into them before you clamp and cut the cord. So that's generally how I practice, but we have no data that those babies necessarily, other than I'll say our Minby trial that took non-vigorous babies and milked their cords. That's the only sort of human data that I have at a high level that says that's how I would intervene on those babies. But picking a biomarker like a SAT or a heart rate and waiting, I think this makes it much more convoluted than sort of just looking at the kid and saying, hey, I'm going to give that kid more time.
I'm going to actually piggyback on that. I know, Audrey, you were going to go ahead and chime in. I'm going to piggyback on that if you don't mind. In addition to your answer, can you enlighten me? We always talk about, oh, for the non-vigorous baby, let's do A, B, or C. We kind of throw that word around like we all understand what that means. But what does, when you're in the delivery room and you're managing this patient, what does non-vigorous mean to you? How do you define that? And how does that shape your strategic approach, piggybacking on what Anup had just said?
That was for Faith, right?
Sorry, to Audrey. I think she was about to jump in on that one.
I was actually going to ask the exact same question to Anup. So I'm going to refer to Anup, saying how do you define non-vigorous, right? Because I think that's a challenge maybe to you versus to me. And I think that has a huge impact of how much you wait. And I do agree these patients probably benefit the most. And I think it's such a challenge when you have a baby who doesn't seem to be breathing, is not a good tone, not crying, and then to kind of keep not clamping, it's difficult. So I'm actually going to ask that question. And then I have another question for Anup as well after.
So Audrey, I mean, the biggest thing, like, okay, so when we go to deliveries, say for let's start with preterm babies, particularly the tinier ones, because babies under 28 weeks, or as you go lower, the anxiety of the obstetricians tend to go up. Most of the babies that come out, they're not always breathing, but they always have generally good tone, or they're moving around. And those are babies that our reflex should be to continue to let them stimulate and let those babies breathe on their own. It's the babies that are completely floppy that I think make people the most nervous. But I would argue preterm babies, they don't get sectioned and they're completely asphyxiated. It's those term babies that we end up having to worry about, that are limp, they're asphyxiated, not doing well. I'm not saying it doesn't happen in the preterm babies, but the majority of them just need time to start to breathe. And I think in those kids, as long as they have good tone, I would just keep delaying and stimulating them. Don't worry if they haven't cried yet. And I wish I had more time. I have another video of this baby who was like a 25-weeker who had good tone but did not cry, and the OB was getting ready to clamp, and I'm in there waving him off, and at 54 seconds the baby makes a little cry and everybody relaxes. But tone should be your number one driver to continue to stimulate. And the term babies, I think if they have poor tone, that's where it gets tricky, because they might be asphyxiated. And then does delay help those kids? How long can the OB wait? That's why we've said, well, if I can't do intact cord resuscitation, I think milking those kids tends to happen. But in both groups that I gave you, term and preterm, I really say tone is the one that I think makes people the most nervous and you should really act on. If they're not breathing or their color looks bad, I would continue to do what you're doing. So.
And can I follow up? I'm going in a different direction, but I'm kind of taking the lead on Amir's first question. So you did talk about oxygen a lot during your talk, which was very interesting, like high oxygen. And we always report the outcomes of IVH mortality, but in preterm infants, when you give this high oxygen, you did mention pulmonary vasodilation, like that's going to have the impact, right? What about kind of the short-term outcome on these preterm infants about PVR, like the risk of pulmonary hypertension, PD? Okay, I can't be the hemodynamic expert and not talk about PDA, right? Like what are the impact? Because I feel like we don't often talk about that, but I mean, it could also potentially be beneficial for these patients. Like if you're going to help their transition and lower PVR in preterm infants, like that might be beneficial as well. But I feel like we don't talk a lot about that in most studies.
Right.
What's your opinion?
Well, I'm excited. Well, we'll see. We do have this study that we are doing. We just put together an abstract for the PAS meeting that looked at 80 babies at an echo at 6 to 12 hours of life, looking at RV, LV function. And, you know, I used to be, and I still am, a very basic sonographer, but some of our sonographers are really good at doing some of the advanced imaging. So we'll show tissue Doppler and some of the other things. And I think you'll be intrigued to know that there are some important effects that are happening on the heart, even at 6 to 12 hours of life in these babies when they're getting exposed to higher oxygen. The flip side is it too much? If you give them oxygen, you drop their PVR too quickly. And I think I saw a question in the chat, is that negative? And I think that gets into your question, are we creating a large PDA? Are these babies going to be flooding their lungs? You know, does that increase your risk for IVH? And I think that's where you need the clinical trial component as well. So I think this study will be a good physiological study. We're looking at NIRS, echoes, and a whole bunch of measures to sort of iron out the hemodynamics in this pilot before we roll it out into a larger RCT.
Perhaps I can piggyback on Audrey's question about the high oxygen. Maybe I'll direct this to Satyan. In terms of, you know, one of the sort of pilot studies that you guys did on INO during transition, maybe could you sort of talk a bit about that potential role of nitric oxide or high oxygen in transition?
Well, I don't want to get into nitric oxide now, Faith. It's a controversial topic, but what Faith is referring to is brief use of inhaled nitric oxide in the delivery room to enhance transition. But let me get back to the original question. I think there was a beautiful comparison between breastfeeding, breast milk, and delayed cord clamping that both Anup and Cheryl did. I just want to point out that both breast milk and delayed cord clamping were meant for late term and term infants who are coming out of vaginal delivery with vigorous crying. And also that's what we use. And just like we need fortification for an extremely preterm infant who is on breast milk, we need something else over and above deferred cord clamping for extremely preterm infants. And the question is, what is that? And that's where the physiological based cord clamping with some degree of waiting for respiratory effort or some kind of respiratory support or increased oxygen, as has been shown by Doxy that Anup and we are investigating, or milking. So all these things are being investigated for that purpose as to what else does an extremely preterm baby need to enhance placental transfusion, unlike a crying term baby. So getting back to the specific question of pulmonary vascular resistance, there was a question by Dr. Ram earlier in the chat. There are studies from way back in the 1960s where Bill O and his colleagues literally went to newborn nurseries and catheterized the umbilical cord and pushed the catheter all the way into the ductus and measured pulmonary arterial pressures and showed that babies who had undergone placental transfusion had higher pulmonary arterial pressures for the first 6 to 12 hours of age, clearly indicating that this extra volume does contribute to slightly higher PA pressures compared to babies who don't get placental transfusion. So the point is that there are so many factors influencing PVR, one being just the blood volume itself. It also could be higher crit that you see in some of these babies. But the purpose of using high oxygen for a brief period of time is purely based on the fact that the primary determinant of pulmonary vascular resistance is alveolar PaO2. And if you transiently increase alveolar PaO2, you tend to decrease pulmonary vascular resistance and improve flow into the pulmonary circulation. And the moment you clamp the umbilical cord, whenever you end DCC, you turn the FiO2 back to 30%. So you can't really leave the baby on high FiO2 for long, because once you clamp the cord, the dilution effect that Anup was talking about is gone. So I think for a short period of time, we hopefully believe that benefits outweigh risks, but only time will tell what the answer is. But we have to be cautious as to how fast the PVR drops. There are clear indications that using too much of nitric oxide in an extremely preterm infant, if you drop the PVR too much, that might actually promote the ductal shunt, as you rightly pointed out. And as Audrey was saying, a huge left to right shunt across the ductus is not good in a very young preterm infant that can put the baby at risk for IVH. So there has to be a balance between all these factors, and only time will tell with all these studies as to what the right approach is. And for the time being, we are hoping that combining a very short period of high FiO2 during the period of transition along with DCC might do the trick, but we'll have to wait and see how things pan out.
That was a fantastic insight. I know that Dr. McNamara has a question. Do you want to ask it, Patrick?
Oh, thanks, Amir. Actually, I want to latch on to what Satyan said there. And I think in what we're trying to achieve is optimal homeostasis during a phase of major change in physiology, and try to minimize the downstream potential ramifications of that. I've heard a lot of discussion around reduction in pulmonary vascular resistance. And Satyan mentioned something there which, kind of struck a chord, is we actually don't know what's happening with pulmonary vascular resistance. And if you become hemoconcentrated, the shear stress may actually cause your pulmonary vascular resistance to go up. Mm-hmm. And I'm just curious to know, Anup, has there been any signal from any of the physiologic studies that perhaps some of this late hypoxemia or this kind of lower SATs that you see, are there some babies that actually have a negative impact to pulmonary vascular resistance? Because the bottom line is you need three things. You need to recruit the lung, you need your PVR to drop slowly, and you need your right ventricle to contract, are the three important determinants. But do we actually know that there's not a subproportion of babies that are getting elevated pulmonary vascular resistance? And again, I don't know that I've seen any of the trials report acute pulmonary hypertension, heart dysfunction, or anything like that ilk. that could be, impacting, because you keep saying choosing the right patient.
Right.
And in choosing the right patient, you probably don't want to increase pulmonary vascular resistance. So just another provocation. This is more provocation. This is not me anti-delayed cord clamping at all. I'm very supportive.
Right. Well, the one thing I'll say, yeah, I think it's a good point. I'll be honest, the early trials that we've done and the ones I've seen in the literature really don't measure RV function well. And again, this goes back to what are you looking for and what measures are you sort of trying to achieve. I'll say again, we have this abstract hopefully that will sort of suggest that you see improvement or a drop in PVR because you're actually not only measuring PVR, but better RV function, looking at TAPSE and other measures of right ventricular function in babies that get 100% oxygen on the cord compared to 30%. But your question is just delayed cord clamping alone. Have there been studies showing adverse cardiovascular effects? And the answer is no. The studies that have, they're not very well done and conducted to really measure, I think, what you're asking. I think for people that are looking for more echo projects, I think that's a great one to do. I think people are doing enough delayed cord clamping to be able to ascertain that. I mean, most of the time we see these babies transition great, and delayed cord clamping, unfortunately, it selects out the really good babies to begin with, because those are the ones that get it. And I think that's what we have to tease out is in babies that are at high risk, what are you sort of seeing? Because I think the crux of your question to me is, are babies that are at higher risk of RV dysfunction or pulmonary hypertension at birth, the pulmonary hypoplasia babies, other babies that you know are going to struggle, what happens when you do delayed cord clamping on those babies and sort of give them that two-head, or are they going to have a clinical phenotype that measures what you're seeing on the echo? And I don't know. I mean, those are great projects for people to look at. Go ahead.
Right. Go back to the oxygen story with Satyan, giving those patients get oxygen, which may be helpful to prevent kind of hypoxic pulmonary vasoconstriction.
Perfect. Yeah. Great.
So one argument, Patrick, is in a preterm infant, do you really want a rapid drop in PVR?
No.
I would say you don't, right? So you want it to happen gradually, and that's what happens in preterm infants. The rate of fall in PVR is much more gradual than a term infant. And I would like to argue that the way deferred cord clamping partially acts is by delaying the rate in drop of PVR, thereby limiting a left to right shunt across the ductus. And that could be one of the mechanisms as to how it prevents interventricular hemorrhage. Yeah. And so that slow fall in PVR might be physiological, and that's probably what nature designed for preterm infants. And DCC further slows this process, and that might be a protective mechanism.
Yeah, I couldn't agree more. It aligns with how I think as well. Thank you, Seth.
It also probably stops people from jumping and putting a face mask on and causing bradycardia and apnea. Just giving the baby some time.
I also want to briefly point out one of the slides that Anup showed with umbilical cord milking. There was a subtle decrease in TAPSE in those babies, right, Anup? The ones that you did. It was a small, significant, but a very small decrease in TAPSE, suggesting that might also be a factor in a high crit, a high blood volume can transiently increase PVR, but no study has shown a higher incidence of PPHN with deferred cord clamping, partly because higher oxygen carrying capacity has such a miraculous help. It helps in such huge ways in babies with PPHN, so that's a big help.
Let me ask a question to our panelists. We've been talking about physiology for the last 10, 15 minutes, which is great. Let's move to the human factor, which is probably the hardest part of things. We've learned from Dr. Katheria that delayed cord clamping is valuable. We're comparing it to breastfeeding, but I have an OB who's inpatient, or I have an OB who's delivering a 27-weeker who's really nervous because they're not crying. Teach me about the human factor there. How do we, or how should we manage that dynamic in the delivery room? And I know there's no easy answer, but has anybody dealt with this recently and had either a successful outcome that they like to report, or oh my God, don't do it the way I did it, that was an epic fail? I've got plenty of those, but how do people on this call manage the human factor?
I think having a nice conversation with OB beforehand always helps, and having a good relationship with OB is always beneficial. One argument that works quite well, in my opinion, in my humble opinion, is that This baby was sitting in utero on this placental circulation for 9 months or whatever duration it is. So what does 90 more seconds matter? And the blood coming in the umbilical vein is having a saturation of 85%. That's much higher than what a baby has in the first minute of life, which is around 65%.
Good point.
So as long as the blood is coming in and the baby has a beating heartbeat, I don't really worry too much about not crying. Like Anup clearly said, a good tone and a good heart rate does reassure me, thinking that the baby will cry in a little while. But on the other hand, if it's a completely floppy baby with bradycardia, that's a different story. I think that would make me nervous as well.
So in the UK, we have a real national drive for this. We have a national ambition to reduce our mortality, and it's a really perinatal team approach. And at the British Association of Perinatal Medicine, we work very closely with the RCOG. There's a Saving Babies Lives Care Bundle. That's a national driver. So we all get audited and we all have simulation training. So I think that's the way to really drive improvement. But yeah, absolutely, having coffee with your obstetric colleagues and being friends with them and having a briefing before your delivery is absolutely key.
Yeah, I agree that I think the briefing is key. And then we ended up putting that on the neo's responsibility. So it's actually the neonatology team now that calls if we clamp or not. So we're actually watching the baby and then we tell the OB when to clamp. So we feel that we've improved our delayed cord clamping because it's not so stressful. So the OB kind of just listens to whatever we decide.
I love that. And the reason I love that so much is whenever you get to difficult decisions, there's often deferred responsibility. Whoever speaks the loudest is what's going to happen. But if right from the get-go, this is our responsibility, we're going to make the call, this is the logic by which we do it, and there's a process, I love that answer, Audrey. Sorry, take it over, Faith.
I think we have a question from the chat box from a couple of the audience. So this is more about what's been recently published in a Japanese technique of sort of having a longer piece of cord and with a single stripping of blood to the baby. Maybe I can just ask Satyan what he thinks of this particular practice. Is this something that, given the evidence that Anup has already demonstrated, is this something that is one that you may consider?
Given the evidence that Anup has shown and the stance taken by ILCOR and NRP, it's tough to go anywhere near milking in babies less than 28 weeks of gestation. But it's hard to argue against Japanese long-standing evidence of cut cord milking, which is very different from intact cord milking. One big difference is that Ryan McAdams and others have shown that with intact cord milking, with every milk, you literally pump in somewhere close to 17 ml of blood, if I'm correct. And then if you allow for placental refill to fill the cord back, you can pump a large amount of blood. On the other hand, once you cut the cord, the amount of blood that you are giving to the infant is much more limited. So I don't know if that's the reason why Japanese have such advantage. But in this day and age, given Anup's pre-mod trial data and the stance taken by both NRP and ILCOR, recommending cord milking in babies less than 28 weeks will be very hard. And I think it's worthwhile not doing it outside clinical trials.
And I guess my final question for all three panelists is, what about babies with congenital heart disease, in particular those with duct-dependent lesions? Any thoughts on how you approach these type of babies?
Yeah, no, that's a really good question. I think there's a real paucity of research in that, and I think Anup's been involved in some of the planned studies. Is that right, Anup?
Yep. Yeah, we're so Carl Box and I and Kevin Hill from Duke are doing a multi-center trial. We have about 20 centers, some in the US and Canada, it's only babies with critical congenital heart disease that get randomized to delayed cord clamping versus early. And it's a sort of morbidity score to look at post-op survival and complications. The idea of if you transfuse enough blood going into surgery, better adaptation, can you see a better outcome? So I do think that trial will hopefully help. I think right now it's a mixed bag. Some providers are comfortable doing a 60-second delay. Like in my institution, we didn't even have to ask our obstetricians. They were just used to doing that. But I do think in, babies who are quite blue, intact, septum transposed, those types of patients, people get nervous. So can we provide some data that there's benefit there? So that is a study we're excited about launching, hopefully next month. So we should be getting our first patient in.
I mean, one point from physiology is that we all think of fetal hemoglobin as something where the curve is shifted to the left. The thing to really remember with fetal hemoglobin is that during hypoxemia, fetal hemoglobin is much more capable of delivering oxygen. That's what it was designed to do. It was designed to work in a situation where the arterial hemoglobin is 25 to 35 millimeters of mercury. So for a kid with pulmonary hypertension or for a kid with cyanotic congenital heart disease, nothing like having a bit more of fetal hemoglobin to deliver oxygen to the tissues. So, and there is no blood bank in the world that carries fetal hemoglobin. It's only the placenta that carries it. So why not utilize every single drop and give it to the baby so the baby can deliver more oxygen to the tissues?
So let me ask you this then, Satyan. Why not just go ahead and drain the placenta and transfuse the baby as soon as they get admitted to the NICU?
God has given you a card, Amir. Where do you want to stick an IV in there? Just let the card do the trick.
You think we can get everything from just from this practice?
Well,
we can maximize it.
You can't. I mean, there are studies showing residual volume in the placenta. The maximum amount of it happens during the first minute, and gradually the volume goes down. But if you do it for a reasonable amount of time, maybe 120 seconds, with a vigorously crying baby, you get a reasonable amount out, and I think that's a fairly good approach. What you're suggesting is a little tricky because once you draw, you never know what all Wharton's jelly, what else you get into the thing. So filtering and all those things become very tricky. But I'm sure at some point we will do a study like that, and I will let Anup answer regarding the volume question.
Well, it's different, right? During transition, I mean, you're giving it to as a baby, as their lungs are expanding, and you're sort of trying to not steal blood from other organs. If you allow the placenta to sort of start perfusing these organs at birth, I think it's a really different, from a hemodynamic standpoint, when you give it later. But people have tried to look at stem cells, right? Mike Cotton's group at Duke has done some nice work there, and Atul's also doing that in Australia, transfusing baby's blood or cord blood later. So we'll have to see.
Anup, do you want to comment on a couple of questions on gravity and C-sections, etc.?
Yeah, I mean, how much time do we have? Who's
We got
we got to wrap it up. Like you got a minute.
2 minutes left if you want to give.
Okay, really quick. I'll give one liner. So gravity, again, vaginal delivery, big trials showed no difference. C-section still worries because you have an open uterus, so you don't have those sort of forces allowing it to continue. So we try to keep babies at the level of the uterine incision at C-section. What's the other question? Hold on. Or do you want to shout them off? DCC versus breathing. So there have been the Ola Anderson did a study in Nepal looking at babies that if you stimulated them and allowed them to breathe better, they actually need less PPV. So it seems like obviously the ideal practice of allowing babies to breathe on their own. I think Cheryl mentioned the point of putting a mask on the face. The babies actually do better if you actually allow them to do self-initiated breathing than jumping on them to give them breaths. And how long to delay? I mean, the meta-analyses and others, are already suggesting going longer, at least a minute now. I really think most guidelines, and I think you'll see this coming from ILCOR at some point, we really need to stop doing 30 seconds. I've said this on podcasts and other things. 30 seconds is not a delay. You need to go at least to 60 in all babies to show any sort of benefit. And what about twins? Sorry, thanks for whoever's doing that. You're cleaning it up. We have included twins in all of our trials. The one group that people get very nervous about are monochorionic twins, what to do in that group. What we've done, and based on some observational data by others, as long as there's no evidence of acute twin-to-twin transfusion, we allow them to get delayed cord clamping in those babies. And hopefully, as more of these trials come out, we can do sort of subgroup analyses to show that it's safe. Remember, twins have an increased 2 to 3-fold increased risk of IVH. So depriving them of delayed cord clamping is increasing the risk of harm versus this theoretical risk of overtransfusing babies. So I encourage you to do it. The best way to do it methodologically is encourage the OB, do one baby at a time. Then wait a minute, it's okay. The other baby can sit there inside the uterus for a little bit longer. They don't have to rush to get them both out. And I think that tends to make them feel a little bit better. Okay, was that fast enough, Patrick? Sorry if I went over.
No, it's perfect.
Okay.
Well, 10 seconds over. We're good.
Oh. All right, well, thank you guys. This is a great session. Really appreciate it. Everybody was fantastic.
Amir, Faith, you guys want to wrap up? Anything you guys want to say or no, or?
Yeah, I think it goes without saying this is an excellent session, and thank you for Anup for your incredible research and sharing all your work with us, and also to all our panelists as well for all your insights and using your experience. So amazing session, and thank you all.
Thank you guys. Great job.
Amir and Faith, thank you, and have happy holidays and a wonderful
Happy
new year,
holidays,
everyone.
everybody. Thank you
Yeah,
very much.
wishing you Merry Christmas.
Everyone.
Merry
Good day.
Christmas.